Okay, sir, let's, looks like that. And then you have the hip socket. Then you have, kind of goes in like this, and you have, so just bear with me, okay? Because I'm not that good of an artist, but kind of like the same thing. Have the other hip socket like that. Okay. And then this actually should be a little bit more like this. Same thing with this one. And then you also have a little, okay. So again, excuse my poor illustration here, but my point is that this is your hip, and then it's supposed to be open right here in the middle, and it kind of looks like that. Okay. So okay. My point is this though, right here you have the hip bones, the femoral bone that goes in like this.
Okay.
And then it comes that way like this, right? And you have the same thing right here. You have the head. Okay. And so these are your bones. Okay, sir?
Yeah. Yes, sir.
When you have a hip fracture, any segment of any part right here has been fractured. That's what that means, okay? A hip fracture. All right?
Yes, sir.
And when we do hip arthroplasty, that means that we've surgically corrected whatever the fracture, whether it was here, whether the fracture was here, whether the fracture was here, but we fixed it. That's hip arthroplasty. Does that make sense?
Yes, sir.
And they will sometimes put pins, and they'll put these bars or whatever the case is. They'll connect these two. My point is that they surgically correct it. They do open internal fixation, which means they open the patient up. They have surgery. That's what hip arthroplasty is. Any questions on that, sir?
Yes. No. I got it.
Okay. What you have to understand is that there's some post-op teachings you should be aware of. First of all, the patient's legs will be abducted. That means that they will be kept separate, away from the midline. So this leg will actually go further this way a little bit more. Okay, this will go further this way. That's how they should be kept after the surgical procedure. They should be abducted. The head of the bed should be low, no more than 30 degrees. Actually, sometimes, so the book says, I believe, 15 to 30 degrees, meaning that the patient's head will not go any higher than this. There's a pillow. No higher than this, because we do not want the hip that's right there to be flexing in this angle. We don't want to put the head of the bed up, because this flexion of the hip will pop the bone out of the hip socket. The hip socket is known as the acetabulum. The acetabulum. That is the hip socket where the femoral head goes in. Okay? Yes, these patients, so again, not that position. They have to keep the legs abducted. The head of the bed, the head of the bed should be low. You will not be flexing the hip. So no flexion of the hip.
Okay.
Until the doctor or the therapist allows it to be, usually after a certain amount of months. For quite some time, for the first 3 months after the surgical procedure, the patient will only be able to flex their hips no more than 60 degrees, meaning that imagine this is the patient's right here, right? And so they will not be flexing anything more than that, meaning from there to there, that's it. No more than that. They should not be no more than 90 degrees, like their leg coming all the way up here. They shouldn't be doing that, because that's going to damage the hip. But we can review that later on in regards to the time frames. But understand that the immediate post-op period, right after surgery, they're going to keep that leg abducted, and that hip, they're not going to flex it until months later. There's a certain amount of degrees that they can flex it. Does that make sense?
Yes, sir.
Okay. Any questions on this, sir?
No, I got it.
Okay.
Let me.
So with that being said, we go back to the question. A nurse is caring for a client who is 3 days post-op following a right total hip arthroplasty. While transferring to the chair, the client cries out in pain. The nurse should examine the client for which the following manifestations of dislocation of the hip prosthesis. Now, what that means is we go back to this illustration.
Okay.
Remember how in this little picture that I'm showing you that the femoral head is right here and the acetabulum, it's there, right?
Yeah. Yeah.
When the hip dislocates, the leg, the femur right here, this bone right here tends to move up. This bone right here moves up because it comes out of the socket and the whole leg gets pulled up. Does that make sense?
Yes, sir.
And because of that, you as a nurse should be aware that when you're looking at your patient, how do we know that they have a suspected hip dislocation? That it became fractured again, or it dislocated from its normal anatomical alignment, or the prosthetics, meaning the devices that we placed in here, have dislodged. That's because you'll see one leg that's this long, but the other leg is that long, because the leg has been pulled up higher, so there will be a shortening of the leg.
Mm.
There will also be lateral rotation. Because the femur moves up, it also starts rotating outward. So the foot's gonna be kind of like facing that way, if you can imagine that. Does that make sense, sir?
Yes, sir.
So again, when you have hip dislocation or hip prosthetic slippage, meaning that the prosthetic, the whatever devices that they use to fix it, it's come out, the leg's gonna be shorter and it's gonna be laterally rotated. Any questions, sir?
No, that's good. I'm cool. I'm cool, sir.
Whoops. Good.
Okay.
Right.
Yeah.
And so that's why it's shortening of the right leg. I understand the bulging, but there may be some type of swelling. It's not specific to hip dislocation, but shortening and lateral rotation, that definitely is. Okay, sir?
Okay.
And you understand why, though, right? Because the leg is pulled up.
Yeah, of course, yeah.
If we go back to the picture real quick, we have muscles that are helping us attach all this stuff. And if you remember, when we talked about the regular femoral fracture, how the bone gets pulled up and it starts digging into the muscles. If you remember, we did this. We had this, and then the bone starts getting pulled that way.
Mm-hmm.
We have the muscles like this, right? So when it's broken right here in the middle, it gets pulled that way, right? Mm-hmm. Well, same thing with this one. When the prosthetics in here, when they don't do their job of keeping the hip, keeping the femoral head in the acetabulum, then of course the muscles that are there are going to take over and they're going to pull upward. So the leg is going to get shorter. Is that clear, sir?
Yes, sir.
All right, good. Okay.
The nurse is collecting data from the client. It's 48 hours post-operative, following a reduction and internal fixation of fractured tibia. Which of the following findings should the nurse report to the provider? A serious drainage from the inside, lines the toenails, beds, pressure, pink tissue around the fixation, incision sites. 48 hours post-operative. Toes both, serious drainage, blanching of the toenail bed, pressure, pink tissue around the fixation incision site. Pink tissue, blanching. I go for D, sir.
You said D?
D, yeah. D as in dog.
Okay, final answer. Assuming so. All right, let's do this one. A nurse is collecting data from a client who is 48 hours post-op following open reduction and tonal fixation of a fractured tibia. Where's your tibia at, sir?
My tibia. Fracture tibia. Tibia is
Where is your tibia at?